Good morning. Can everyone hear me? I don't know that the mic is on.
Yes, we can hear you.
Can you hear us? Can you guys hear me? No, it's not on. Good morning. Our speaker today is Jenny Alexopulos, DO. Our speaker today is Jenny Alexopulos, DO. Our program is underwritten by an educational grant through OSU Medical Center, Graduate Medical Education. A disclosure statement has been signed and is on file in the Graduate Medical Education Office. Dr. Alexopulos is a graduate of the Kirksville College of Osteopathic Medicine at Kirksville, Missouri. She completed her rotating internship and family medicine residency here at OSU and has been actively involved in the graduate medical education during her professional career. Dr. Alexopulos is board certified by the American Osteopathic Board of Family Physicians. She is the statewide director of the Clinical Learning Environment Review, representing the Oklahoma State University Center for Health Sciences in the Osteopathic Medical Education Consortium of Oklahoma. She serves as the OSU Medical Center Family Medicine Residency Site Director and is a professor of family medicine with the Oklahoma State University College of Osteopathic Medicine. Dr. Alexopulos serves as a member of the Oklahoma State Board of Health, representing Ottawa, Delaware, Craig, Mays, Nowata, Rogers, Washington, Tulsa, Pawnee, and Osage counties. The Cloud CME activity code for today's grand rounds is 1576. Please welcome Dr. Jenny Alexopulos.
Thank you for that kind introduction, Dr. Mercer. Well, today's topic is a clear topic. So today's topic. Yes, no? No. Hello, better. Okay.
Yes, better. Thank you.
Okay, thank you. Today's topic is a clear topic. So this is a clinical learning environment review topic, and it is a topic that across the country has been somewhat challenging in terms of harmful events and how we disclose these events to patients and their family. It's not, no. Where? Okay, thank you. All right, so I have no disclosures and no conflicts of interest. And so this is one of our requirements whenever we give presentations. If you give presentations in your didactics, you should always have a disclosure slide and disclose any potential conflicts. So our objectives today are to discuss the different types of adverse outcomes and to discuss the importance of event analysis. So when something goes wrong or you have an unanticipated injury with regard to patient care, we want to talk about the importance of event analysis. There is a model called the WHO model, which you're going to hear later in this video. And the WHO model has an impact on adverse outcomes. We're going to discuss the Swiss cheese model and the importance of error disclosure, the ethical complexities that occur when physicians and facilities actually disclose these errors. And what does the patient and the family expect when there is an error disclosure? What do they expect to hear? And then how would you determine how you would disclose an error to a patient? We're going to talk about the Oklahoma apology law, and we're going to identify who the second victim is. So there are 6 focus areas in CLEAR, and this presentation will touch upon all 6 focus areas of patient safety, quality improvement, professionalism, teaming, and supervision, as well as well-being. So the concept of errors and the complexity of the healthcare environment, the very dynamic nature in which we work, the idea of these fatal hospital mistakes really started being discussed in the community back in the late 1990s, as well as in the early 2000s. So the community became quite aware that these issues do occur. And here's a retained foreign body. So this really accelerated an intense interest in disclosure. There are some states that actually have disclosure laws, and you'll find as we go through the presentation that there are some states that actually have an apology statute or apology policies. And there's been a lot of experimentation as to how a disclosure should occur and what its content should be. So this has been evaluated by healthcare organizations across the country and malpractice insurers. The National Quality Forum is an agency that has developed new standards around this as well. So, and it really is an effort to increase the transparency of healthcare in general. Clearly, there is a performance gap in this country, and that in general, most harmful errors are often not disclosed. And when they do occur, unfortunately, patients relate to us that it really falls short of their expectations in terms of content. And unfortunately, there's very little evidence to regarding what kind of strategies hospitals and physicians should follow. So the outcomes of it is actually quite unclear. He amputated the wrong leg. Still, he was a very nice fellow, best not complain. Not to make light of a serious issue, but it does provide a degree of levity. With regard to the common errors, you can take a look at this slide. There are retained objects, wrong patient, wrong site, tight casts, anesthesia, mishaps, transfusion errors that occur. These are just some. And then let's talk about adverse events. Well, we have medical errors in general. And then within the medical errors, we have those errors that don't reach the patient that are called near misses. And it really is important that we identify those near misses so that we can study those and intervene so that that harm does not reach the patient. And then we have these adverse events or complications that are that can be preventable or non-preventable. And you can see our Venn diagrams kind of overlap there. So it's important as we see our patients and we identified errors that, we have an incident reporting system here at OSUMC. It's called Verge. And so by entering these near misses or entering these adverse events, it allows the facility with the involvement of the physicians to actually investigate and identify processes to prevent further errors. So what's the rationale? Well, when you think about it, error disclosure is a form of informed consent. We provide informed consent for those patients that are about to undergo a procedure or surgical surgery of any kind. And so, and we talk about those risks that occur and the risks and the benefits. And so error disclosure is really just a continuum of the informed consent process. And I think we have a positive obligation. We have an obligation to inform our patients of those errors. And it's a form of truth telling in healthcare. You'll find that there are some regulatory requirements around disclosure. JCO, National Quality Forum. There are some state laws. And the disclosure gap is real. And when they've done a study of the number of errors that occur in the country, the disclosure rate is really pretty low, about 30%. The question is, what is the content of the disclosure and does it have an impact? So the ethical complexities for a physician or for a healthcare facility is, should I disclose? Should I disclose errors that have maybe some minor or transient harm where perhaps the patient is unaware that the error occurred? Or should I only disclose those errors where there's a fatal error, where there is a unforeseen outcome? Should I disclose those errors with patients that are debilitated, that have chronic diseases, where those harmful errors really didn't change the trajectory of that patient's care? And should we disclose other physicians' errors? So these are all ethical complexities in determining error disclosure. And there's conflicts of interest. Does it harm my fellow healthcare workers to disclose this? Is it even morally relevant? Now let's shift to the patient's attitudes about disclosure errors. Okay, so for the most part, patients really perceive this disclosure in general, these errors in general. They really don't understand the specifics of the medical errors specifically. So their perception is a pretty broad perception. And what they really want is a full disclosure of all of the harmful errors. So it needs to be relayed in lay terms. And I think that for the most part, communities worry that healthcare providers or facilities that provide that care might hide those errors. Okay, so there is a general lack of trust. So what's their preference? They want the information disclosed. They want us to be explicit about it. They want to know what happened, why it happened, and they want to know how we will prevent this from happening in the future. And the importance of an apology. And there's been quite a bit of discussion about the content of that apology. Should we be saying, I'm sorry that this happened to you? Or should we be saying, I'm sorry this happened to you because of an error that I made? Okay, so there's a lot of discussion across the country by healthcare lawyers, by healthcare systems, by physician groups as to the content of the delivery of the actual apology. So now let's talk about the physician's attitudes about errors, and this has been surveyed across the country, actually in North America. Physicians typically really describe these errors more narrowly and more specifically as it pertains to the particular error that led to the adverse outcome. They agree in general, in principle, that full disclosure is important, and they want to be truthful, but there are certain experiences that physicians have that actually provide some barriers for that disclosure. What are they? Well, we're concerned that the disclosure could cause a lawsuit to ensue. There's a fear that the potential disclosure could actually harm the patient. And we worry that it could be potentially awkward and uncomfortable. So physicians, as you know, we are held to the highest standard in the community. We are expected to perform at our highest level without failure. And so it is difficult for physicians to really admit our personal failures. And quite honestly, none of us have really had any formal training in error disclosure. So this is a relatively new topic, and it doesn't mean that we can't learn along the way, because we're lifelong learners. So in general, you want to choose your words very carefully when you're disclosing errors. You want to be relatively explicit about what the error was. You want to talk about prevention, about what you're going to do or what your facility is going to do to minimize this risk happening to another individual. And you want to leave kind of an open dialogue and leave those patients and their families time to digest the information and ask some clarifying questions. And the real concern is, there's a legal liability that it comes with an apology. So here's some preliminary survey conclusions. In general, physicians support the concept of disclosure. Content is still questionable in terms of what is the best approach. And the medical and surgical fields may have a different approach to error disclosure. So there's a safe practice, and really professionalism is at its core here. Transparency should be a core value, found to be a core value of what we do. And there's a direct link between disclosing an error. So you have an incident reporting system, you disclose the error, or you submit the incident, it's investigated, you have an outcome, it's shared with our medical staff, and this will also allow for performance improvement. So it's all tied together. Patient safety, quality improvement. So it's important that as we disclose, as we develop a policy or procedure for disclosing these errors to patients and their families, that the healthcare workers actually have a support system in place, because there is the concept that when this occurred, there is what we call a second victim. And in the video that I'm going to be showing here shortly, it will go into that second victim and the support that the healthcare workers need when these types of events occurs. So we talked about some of the national agencies that actually have regulations around this issue. JACO calls them a sentinel event. I'm sure you've heard that term. National Quality Forum call them serious reportable events. And in general, many others actually define an error like this that needs to be disclosed as any harm that causes substantial additional care or prolongs their hospitalization or their disability beyond 7 days in duration. So, however, disclosure can be very appropriate for less severe events. So one of the things that they do recommend in terms of the content of the exposure, if you don't know why the event occurred, if you don't know why the adverse event or harm occurred, then don't rely on supposition, okay? Just present the facts as you know it. If you don't know why it happened, then say you don't know why it happened. And then focus on the preventability. An expression of regret is very important. And let them know that you have a commitment to investigate and prevent any future occurrences. Talked about that. So now the apology. So there's 35 states that actually have an apology law on the books, okay? And the protections vary very widely. It doesn't mean, just because there's an apology law, it doesn't mean that you can't be sued, because you can. 7 states actually have mandate disclosure. The impact is somewhat limited, but here's our Oklahoma law. This is our statute. And basically, you can read this on your own, but basically it says, if you disclose to a patient that harm occurred as a result of error, the plaintiff's attorneys cannot hold that as an admission of guilt, okay? So basically, it says it can't be used against you. You cannot use it as an admission against interest. So admission against interest. I want you to remember that term because it's evident here. So this is our Oklahoma law. Again, the institution should provide support for us and support for patients and families, even after the event and the disclosure occurred. This is an opportunity for us to build on education and skill building. And the institution should provide us with some coaching because there are times when we might have to disclose as the event has occurred, okay? And it's important that we kind of articulate the vast majority of errors that occur in this country are never, patients and families never sue. Now, why is that? Is it because there's a lack of awareness that the error even occurred? Or is it suggestive of a disclosure may increase litigation? We don't know. So there's some anecdotal evidence out of the University of Michigan, and they've been doing a disclosure for over 5 years now. And basically in the first 5 years, they've noted that their litigation costs went down from 3 million to 1 million. The average time to resolution of these cases went from 21 months to 9.5 months, and the number of total claims went down from 262 to 114. So there has been, at least in some big health systems, an economic benefit. All right, and now I'd like to show a video. Dr. Gotham is a professor of pediatrics at Baylor College of Medicine, and he's done some extensive research on disclosure of errors in RCAs, and I think he does a really great synopsis. So I'm going to ask Heather out in Zoom land to start our video.
Medical Error, From Disclosure and Apology to Root Cause Analysis by Dr. K.S. Gotham.
Hello, my name is Gautam Suresh. I am a professor of pediatrics at Baylor College of Medicine and section head and service chief of the neonatal intensive care unit at Texas Children's Hospital in Houston, Texas. For many years, I taught a course on patient safety and I have done research in this area. So it is my pleasure today to talk to you about medical error from disclosure and apology to root cause analysis. I do not have any conflicts of interest to disclose. And in today's module, we will be addressing how do you respond to errors or adverse events and what are the steps you need to take. Obviously, the first action is to protect the patient and ensure ongoing clinical stability. We also have to take care of the second victim, that is the nurse or physician or other health professional involved in the incident. We have to let our risk management colleagues know about the incident and get their advice. We have to analyze the event, both immediately and in subsequent meetings and analyses. And finally, an important part of today's discussion will be about disclosure and apology to the patient and the patient's family. Let's talk a little bit about the second victim. As I mentioned earlier, the health professional involved in the error or adverse event is known as the second victim, the first victim obviously being the patient and the family. And based on multiple research studies, we know that second victims tend to go through a lot of distress and suffering as a result of being involved in the incident. They may experience profound guilt, self-doubt about their competence. They may be embarrassed to show up at work and face their colleagues. They may be disappointed in themselves and blame themselves for harming the patient. They may be riddled with a sense of fear and a sense of inadequacy. And they may have difficulty sleeping at night. They may have recurrent anxiety about committing similar errors in the future. And many of them, unfortunately, develop dysfunctional coping mechanisms such as denial, distancing, discounting. And the tragedy of such dysfunctional coping mechanisms is ultimately neither they nor their colleagues learn from the error, and they end up losing out on an opportunity to learn from the error. The effects of the second victim distress and they're going through all this suffering are aggravated by our medical culture of infallibility and perfectionism, where we expect nurses, physicians, and other clinicians to be perfect in their job and never make any mistakes, which is contrary to the nature of being human. We also suffer a lot from pre-existing stress of medical training, and the second victim phenomenon is often superimposed on such pre-existing stress, which makes it harder to tolerate. Many clinicians work in an environment where colleagues are not supportive and their supervisors or leaders are not very supportive or forgiving, and that itself makes it very hard for them to go back to work and function in the same environment where they were involved in a medical error or an adverse event. And many institutions don't have formal programs and support mechanisms to help the second victim. Therefore, many of them suffer and cope on their own, and as a result, develop the dysfunctional coping mechanisms that I mentioned in the last slide. Second victims can also suffer from many long-term effects. For example, they're prone to burnout and depression. Their job satisfaction may plummet. They may have an increased predisposition to committing more errors in the future. And that sets in place a vicious cycle where their participation or involvement in errors leads to more of trauma and distress, and that in turn leads them to commit more errors. Ultimately, many of the second victim clinicians can end up developing a defensive practice style where they underuse or overuse tests and treatments just out of fear of making a mistake. To help second victims in our institutions, the best practices that all of us can follow are having good mechanisms for debriefing, where we provide just good listening, emotional support, encourage them to talk about the event and express their emotions and their distress. Of course, such meetings should always be quality assurance protected according to the state laws. Reflective writing is another very powerful tool where people are encouraged to write about their experiences and thoughts, and they're encouraged to write in a stream of consciousness way without pausing to edit, correct, fix the grammar or the spelling, or to get the writing perfect. Once they do the writing, they don't even have to show it to anybody, they don't even have to read it themselves, but just the fact that they write down their thoughts in a stream of consciousness way has been shown to be very helpful in processing the event. When second victims are allowed to participate in disclosure and apology mechanisms, it's very helpful for them and it helps their healing process. Giving people time off from work if they've been involved in a difficult incident is always good. And we should be offering professional counseling access to clinicians who have been involved in adverse events, especially if there's patient harm. And we should get in the habit of following up and providing repeat support sessions for these colleagues of ours. I mentioned debriefing in the previous slide, and debriefing ideally should be done after every critical incident in your unit. Debriefings can be done immediately after the event, in which case they're known as hot debriefings, or they can be done several days or weeks after the event, in which case they're known as cold debriefings, or sometime in between, in which case they're known as warm debriefings. In a good debriefing, we have to set a safe atmosphere and set the right tone so that it's a learning experience and not a punitive experience. And the facilitator has to create an atmosphere which feels non-threatening, but at the same time, it's not frivolous and people do take the whole discussion seriously. The discussions have to be non-judgmental and non-critical. We have to display extreme sensitivity to people's emotions and feelings and what they might be going through. Again, the key to good debriefings is good listening on the part of the facilitator. And non-verbal signals by the facilitator are very, very important. And if people demonstrate some sort of criticism or judgment or questioning through their non-verbal signals, that can derail the learning process in a debriefing. One simple way to conduct a debriefing is to ask 3 open-ended questions. What went well? What could have been done better? And what should we do differently next time around? There are other methods such as the plus delta method, where we talk about what went well and what could be done differently. And finally, I would encourage all of you to read this very important article published by Rudolph and colleagues in 2007, which is known as Debriefing with Good Judgment. And they talk about the various approaches that one can take to debriefing and end up recommending this debriefing with good judgment approach. Let's move on now to event analysis. After every serious incident in the unit, we should get in the habit of analyzing what led to the event, what factors contributed to the event. And many of you will be familiar with the term root cause analysis. But how many of us have seen a tree with just one root cause? Most trees have multiple roots and rootlets. And so also when we investigate an event, we have to recognize that there are multiple causal and contributory factors that lead to the occurrence of an event. One framework that I would like to suggest to help analyze events is called the WHO model, where W stands for work environment, and we try to identify error-producing conditions in the work environment. H stands for human fallibility, and we try to understand how the humans involved in the incident went through various cognitive processes and made decisions that made sense at that moment in time, but later on backfired in some way. And finally, the whole organizational context in which the work is done and the humans are functioning also is very, very important as a macro or high level factor that contributes to error. So when an error occurs, we have to ask who is responsible, and the who in this case stands for work conditions, human conditions, and organizational conditions. Examples of these three domains are listed in this slide. For example, under work conditions, heavy workloads and unhealthy shift patterns could cause people to be fatigued and make errors. The design of equipment, the availability of resources, and the maintenance by biomedical departments can also cause malfunctioning of equipment. And those could be the overall systems causes of errors and not carelessness by an individual. Amongst human factor examples, the various categories are staff knowledge and skills. Staff emotional state and stress may also contribute to an error. Amongst organizational conditions, financial resources and constraints that limit the number of staff available or cause overburdening of existing staff with excessive patients, and safety culture and priorities, where people may not feel safe speaking up about safety concerns and they may feel afraid of intimidation or retaliation, is an important organizational condition that predisposes to lack of safety. Many of you will be familiar with this Swiss cheese model proposed by James Reason many, many years ago. Because we are all aware of the possibility of error causing harm to patients, institutions put in place many defense mechanisms to intercept the error. And most often, the error is intercepted, say, by a vigilant pharmacist or electronic order entry system that double checks your dose, and the error does not reach the patient. But once in a way, as they say, all the holes line up and all the weaknesses in every layer of system are in one straight line, so that the error propagates through the system and reaches the patient and may even cause harm to the patient. So ultimately, when we do a systems analysis, we're trying to reconstruct the event and trying to walk through the event prospectively to understand what exactly happened. When we're doing this, it's important to avoid hindsight bias, also known as the retrospectoscope, because with hindsight, we can always say they should have done this, they shouldn't have done that. But what we are trying to do when we do a prospective walk through the event is to try and understand why did the actions and decisions of the people involved in the event make sense at that point in time for them. So ultimately, we're trying to answer one of the important questions. Was this an adverse event related to the healthcare interventions, or was this a natural complication of the innate disease of the patient? That's one thing we have to try and tease out. Next, we have to try and understand, was this adverse event the result of an error, and how confident are we that this was the result of an error, and how much did the error contribute? Was it entirely responsible for the harm to the patient, or was it contributory only partially, and the rest was the patient's own disease and biology? Interestingly, when we're trying to do systems analysis, we often discover unrelated errors, and those should be put aside in a parking lot for investigation later, because those are also valuable insights into your system and systems flaws that can help you promote safety overall. Ultimately, after doing an analysis, we try to classify events into errors or adverse events, and errors may result in adverse events, which is the overlapping circle, and errors that don't result in harm to the patient are known as near misses. And this visual also reminds us that many times adverse events are not the result of errors, meaning sometimes we do everything correctly and the patient still has an unanticipated event that was not preventable. When the Institute of Medicine first published their seminal report To Err is Human, they emphasized that we should move away from blaming individuals and start looking at the whole system as the source and the locus of the origin of errors. But after a few years, people got worried that individuals were not taking enough accountability for safety events. And so this movement called Balancing No Blame with Accountability emerged. Here's one example of how institutions can try to balance no blame with accountability. This is an approach called the just culture, where you try to classify the behavior into human error, at-risk behavior, or reckless behavior. And if it's a simple human error which was inadvertent, committed by well-intentioned individuals, you console and you focus on redesigning the system so that it's hard for humans to commit similar errors in the future. If there was at-risk behavior, then you coach the individual, and if there was reckless behavior, you punish the individual. This is an example of a decision tree from the UK, where you systematically go through multiple steps and try to answer questions to identify whether specific individuals should be accountable and culpable for their actions, or was it entirely a systems-based problem with well-intentioned individuals trapped within the system. And I would encourage you to read an enlarged version of this slide later on and study the flow of decision making in this flow diagram. Finally, let's move on to disclosure and apology, which is one of the most important aspects of responding to adverse events. The old approach many years ago used to be to deny and defend, and refuse to talk to the patient or the family for fear of being sued. This often led to an adversarial relationship, and it's well known that many times lawsuits are driven by the family's desire to actually find out what happened and by their suspicion that there was a cover-up and they were not being told the entire truth. So this was also not serving patients well, because only 2 to 3% of patients harmed by negligence pursued litigation. So it was not even helping patients universally. And ultimately, even amongst those who pursued litigation, only about half received compensation. So this old approach was not working. Fortunately, today we function in an atmosphere where disclosure is not optional, but is required and recommended, both ethically and by regulatory and expert organizations. Most hospital policies mandate this, and we should all learn how to perform disclosure well, appropriately, and at the right time. Patients and families too expect full disclosure, and importantly, they want the health professionals and the organization to acknowledge their responsibility in the event. They want to understand what happened. They want to feel and hear expressions of sympathy and sharing of the distress that they are undergoing. And one of the most important things for families is to know that the healthcare system and the health professionals are taking steps to prevent recurrence of the event so that future patients are not hurt. Good disclosure has many benefits. It increases the trust in the healthcare system. It maintains the physician-patient relationship. We don't add insult to injury like in the old days. It may help reduce emotional distress. It aids the healing process. And a couple of studies have actually found that good disclosure may actually reduce litigation. And if litigation occurs, the total amount of the settlement is actually lower than without disclosure. So how should we perform a disclosure? Ideally, the disclosure should be performed by an attending physician or a senior staff member. It should be timely. That means as soon as possible after the event. But obviously, the patient and the family should be ready to hear the conversation. During the disclosure, we should avoid speculation and what's known as hyper disclosure, where you speculate about what might have happened and start taking blame on yourself without knowing the full facts about the event and how things evolved. So we should be very careful during all disclosure conversations to convey only the known facts and not speculate. But we should promise the family and the patient that we will provide more facts after the full investigation. Apology is an important component of disclosure conversations, and as in the debriefings, non-verbal communication is very, very important. We should be following best practices for difficult conversations and sensitive conversations, like sitting down, not using jargon, being slow and methodical, and most importantly, listening as much as we can. The primary purpose of disclosure is not to relieve physician guilt or nurse guilt, and is not to reduce the risk of liability for the hospital. The primary purpose is to provide transparency and to maintain the ongoing patient-family relationship. Families can have various reactions to disclosure. They can demonstrate anger, grief, or loss of trust. But families can often be very forgiving and understanding of how things went wrong. Implementing safety solutions often provides a lot of solace to families, and that's something we should always fold into the disclosure conversations at the right time. As I mentioned, apology is a very important component of disclosure, and Aaron Lazar has published that there are 4 important components of an apology: acknowledgement of the offense, an explanation of how things went wrong, an expression of remorse, shame, and humility, and finally, reparation and compensation of some kind. I'm sorry is a phrase that we commonly use during apologies, and I'm sorry can be an expression of sympathy or empathy, but it can also be interpreted as an admission of wrongdoing. So many states have now put in place laws that prevent the phrase "I'm sorry" being used in a lawsuit as an admission of guilt or wrongdoing. And I would encourage you to look up the apology laws in your state and learn how they recommend you use apologies and the phrase "I'm sorry" during disclosure conversations. And also, obviously, talk to the risk management people and look up your hospital policies. I would like to end with this quotation from Elizabeth Kubler-Ross that says, "There are no mistakes, no coincidences. All events are blessings given to us to learn from. And ultimately, we need to learn from every adverse event and every medical error so that we can make the system safer for future patients." Thank you for your attention.
All right. So there you have a wrap up of error disclosure, second victim, the apology, the content of the apology. And so are there any questions from our audience with regard to this topic? Do you see anything in chat, Lisa? Okay. All right. Well, with that, I hope you have a great day and a great rest of the week. Thank you so much for tuning in.